Hello everyone and welcome to today's webinar for mental health professionals using eHealth to increase the reach of evidence-based treatments for PTSD, lessons learned from the Web PE studies featuring Carmen McLean. My name is Astrid Masfar. I am the Senior Education and Outreach Coordinator here at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select telephone in the audio panel and the dial-in information will be displayed. You will have the opportunity to submit any questions by typing them into the chat box located on the control panel. You may send in your questions at any time and we will address them during the Q&A session at the end. If you registered and paid for a CE credit, you will need to provide the 4-letter CE code in the webinar evaluation. The CE code will be shared at the end of the presentation and the link to the evaluation will be sent to each participant within 48 hours of this presentation. The post-test assessment will occur at the end of the webinar. The questions will appear on your screen and you will be given 10 minutes to complete the assessment. Once complete, please click Submit. I would now like to introduce today's presenter, Dr. Carmen McLean. Carmen McLean is a licensed clinical psychologist at the Dissemination and Training Division of the National Center for PTSD at the Palo Alto VA and a clinical associate professor at Stanford University. Her research examines ways to increase the reach of exposure therapies for PTSD by addressing implementation barriers and testing eHealth and mHealth interventions. I will now pass the screen to our presenter. There will be a brief pause while I do so.
Okay, all right. Thank you very much, Astrid, for the introduction, and hello to everyone who's taking the time to join. Thank you very much. I hope the next hour is interesting for you, and thanks very much to ADA for the opportunity to share some of my work. My background is mostly in research, like traditional treatment outcome research, but I have shifted more recently to focusing on dissemination and implementation issues, and in particular, how we can use technology to try to increase the reach of treatment. So that's what I will be talking about today. And a few disclosures. My views don't represent the DoD, the VA, or the government. This work was supported by VA resources, and the Web PE studies that I'll be talking about were funded by the DoD. So just for some background, I'm going to go over some of the barriers to accessing traditional face-to-face mental health treatment for PTSD. And these are just some that came to mind for me. First of all, geography. So many people don't have any mental health treatment really available to them where they live, especially those in rural areas. Mental health treatment is often cost prohibitive for many people, even those that have insurance. Many providers don't accept insurance, so that is a barrier. There's just the time in, driving to a session, waiting, having the session. It's often only offered during traditional work hours, so you're having to take time off work or sort out childcare. There's kind of that hassle factor. Stigma is potentially, improving, but remains an important barrier for many people. And scarcity, there just are not nearly enough providers who treat PTSD, and there really never ever will be. And so that's why, again, I think it's really imperative that we look to other ways that we can get treatments that might help to people that need them. Avoidance is, of course, a defining characteristic of PTSD. And if you think about, if you're not comfortable really leaving your house, or not comfortable driving, or being in like a crowded waiting room at a clinic or hospital, having to endure those kind of situations to get treatment is going to be a deterrent as well. And related to that point, we know from research that PTSD severity, symptom severity, is positively correlated with the perception of access to barriers. And that this relationship is actually, it's the avoidance symptoms in particular that's driving it. And this is bad, because this means that the people who really need PTSD treatment the most may be the least likely to access it, because they perceive so many barriers. For those that are able to overcome all of these barriers to access and do actually seek treatment for PTSD care, the probability that they would receive an evidence-based treatment for PTSD is not great, because on the other side of things, on the provider side, there are a lot of barriers to implementing evidence-based treatments. There's a whole literature on implementation barriers. These are just a few I wanted to highlight, but often there are attitudinal or attitudes or beliefs. These could be related to manualized therapies in general, or EVPs. My training and research is in exposure treatments in particular, so I think there's an additional layer of sometimes misconceptions about exposure being intolerable or potentially harmful that you have to that can be present. Lack of training for EVPs is a big problem. Lack of post-training support, consultation, supervision is also a major barrier. We know that's really critical from the implementation science literature. We know that's important for the adoption and sustainment of a new practice. Sometimes there are treatment factors that are barriers, like prolonged exposure is meant to be delivered in 90-minute sessions. So if you don't have that much control over your schedule and you see people in 1-hour blocks, then that itself could be a barrier. Organizational factors is kind of broad, but this could include things like, is the culture where you work, is it supportive of EVPs? Is that like an expectation? Is that a priority that that happens? Is there any accountability on it? Or sometimes there can be competing priorities. If you're in a clinic where the priority is access to care, which is very important, but patients aren't really being terminated or maybe triaged that effectively, and then you might have a massive caseload of patients that you can't see on a weekly basis. You're seeing them once every couple of weeks or once a month, and then that there's no way you can do any EVP in that scenario. So a lot of implementation barriers as well. And putting these kind of together in a broader frame, I really like this figure. It's not to scale, obviously, but it shows that among everyone with PTSD, we know only some are getting diagnosed, fewer are getting any mental health treatment, fewer are getting an EVP, fewer are getting an adequate dose, and even fewer are benefiting. So it's kind of a downer of a figure, but it's really important, and I think it's a good reminder that the public health impact of our work is really, it's a function of the reach of these interventions and their efficacy. I think even on the efficacy side of things, there's certainly plenty of room for improvement, for our treatments to be more helpful for more people, maybe more efficient. But even holding that side of the equation constant, we have pretty good treatments that really people are largely not getting and not having the opportunity to potentially benefit from. So to accommodate these many challenges, we really need to have flexible models of care delivery so that we can meet trauma survivors where they are, both geographically and psychologically, et cetera. Sorry about that. Okay, here we go. So I think I think this is where technology can really be very advantageous. And we can think about technology integration as existing on a continuum. So on one end, there's psychoeducation and monitoring. This could be like a website or a mood monitoring app, something like that. Self-management tools. An example of this might be the VA's PTSD coach is a really nice self-management mobile app. Therapist-supported programs include like most of the internet delivered treatments. This is where the WebPE program that I'll be telling you about today falls in, or other internet CBTs like in therapy is another, probably the most researched program for PTSD. Therapist delivered would include things like telehealth, and then therapy augmentation could include, EMA or psychophys, a lot of different things, or also apps like the VA's PE coach or CPT coach that are meant to be integrated with face-to-face psychotherapy. So again, I'm going to focus mostly on the therapist-supported programs. That's where the WebPE falls in. And in general, meta-analyses of these kinds of programs have found really pretty large effects when compared to waitlist, and then small effects when compared to active controls. However, a pretty large caveat with this is that almost no studies have even used active controls for PTSD programs. It's mostly been compared to waitlist condition. So we know that these programs work. We know less about how well they work relative to other things. I'd also just say that this literature for PTSD in particular is a little bit less developed than internet treatments for other disorders like other anxiety related disorders or depression. And I also wanted to mention here about therapy, which, as I said, is probably the most well-researched internet program for PTSD. And therapy is it's a CBT program. It includes a written exposure component. There's cognitive restructuring. There is a farewell kind of ritual component to it. And then the participants are getting pretty detailed, individualized written feedback from a therapist asynchronously. So in therapy has been studied a number of trials. For PTSD, it's only been studied relative to waitlist. So we don't have any active comparators for that. The other interesting thing within therapy is that most of the studies have found really, really low dropout, which is kind of unusual for internet treatments. Then the largest study of therapy actually had higher dropout, like 50%. So again, a little bit, the field here is not large enough that I feel there's a lot of variability at this point. Okay, so I want to talk about WebPE now and explain sort of the rationale for the impetus for the project. So when we were developing this study, we looked at we saw there's other web treatments for PTSD that are available in therapy. There's a number of other ones. None of them really correspond to existing evidence-based treatment protocols for PTSD. They're essentially new programs. And since there have been, so many different PTSD treatments that have been developed over the years, but only a few that have really, gained traction and gotten, received a significant evidence base, we felt that developing a new online program was not really capitalizing on this existing, rich body of evidence that we have about which treatments work for PTSD. So for that reason, we decided to instead try to kind of translate an existing evidence-based treatment and PE in particular, and translate prolonged exposure for delivery online. The other consideration when we were developing the project was the fact that prior studies had really not had an active comparator. I think at the time there was one study that had an online supportive comparator. And so we really wanted to have something that was active. And we thought it would be really valuable to compare an online treatment to the standard of care. And the standard of care is face-to-face treatment. And no study had done that at that time. So we thought that would be really important contribution to be able to directly compare the online treatment to face-to-face treatment. We thought we might be able to do comparative we considered face-to-face PE, but we thought this is a completely novel program and our first evaluation of it, so we don't want to compare it to like the gold standard first-line treatment. We want to choose something else. We chose presence-centered therapy. For anyone not familiar with prolonged exposure, there's a breathing retraining component, there's psychoeducation about common reactions to trauma and the role of avoidance and negative cognitions in maintaining symptoms. And then the real meat of the treatment is in vivo exposure, which is done outside of session for homework, and imaginal exposure and processing, where they're recounting the memory of the worst traumatic event out loud, and then they're listening to that recording as part of their homework outside of session. All right, this is some screenshots of the actual WebPE program. So here you can see someone was we had a few self-reports that they did periodically at the beginning of the session. They could indicate that they wanted their therapist to reach out to them at any point during the program, which didn't happen a lot. The therapists were actually pretty in touch with the participants anyway. That was another feature that we had. We also had a system where if their symptoms increased by a certain amount, that would also send an alert to the therapist, who could then check in on them. Here is where they would record their imaginal exposure. This was recorded on a separate device, either on their computer or their phone, so the therapist didn't hear the imaginal exposure. Before they got to this point, the participant would have watched a video of someone explaining the rationale for imaginal exposure. They would have watched videos of the procedure being demonstrated for them, being modeled for them, and then they would have read through the instructions. After the imaginal exposure, there's the processing. This was kind of the hardest part to translate to online format, because processing is the part of PE that's kind of the most open-ended and fluid and sort of Socratic questioning and so on. What we did is we asked people to indicate the themes and emotions that came up for them, and then we had some videos and a series of sort of questions that were linked up to each of those. And those did sort of change over time throughout the program as a whole, the course of treatment. All right, so the first of the two web studies that I'll be sharing with you today, the first one was a randomized controlled trial. We were targeting 120 participants, soldiers that recruited at Fort Hood, Texas. And participants were randomized to either 10 sessions of WebPE or 10 sessions of presence-centered therapy. Our main outcomes were PTSD as measured by clinician interview, and then also self-report of PTSD and related constructs. And here's what happened with the WebPE. So we had some pretty significant recruitment problems with this study. You can see the dotted line at the top is that was our hopes and dreams for the study, and then the green line is what actually happened. And if you followed out, you can see there's really no way we were gonna meet our target in the time that we had left. We were also seeing higher dropout from WebPE than PCT, which is not that unexpected because it's a web treatment, but that was another concern. So at this point, we actually like paused the whole study and kind of realized that the reason we were having recruitment problems was probably because of the study design itself. And I'll explain what I mean by that. So there are, I don't know how large these groups are or how much they overlap, but there are some people that prefer in-person therapy. They want to sit in front of someone and they want to talk. There's other people that would rather be at home. They'd rather do an online treatment. I don't know how much these groups overlap, but I don't think that they overlap enough that we could recruit 120 of them at Fort Hood. So that was one problem. The other is, and we related to that, I guess. If you think about who's the target population for an internet CBT, the target population is people for whom mental health treatment is traditional mental health treatment. It's not available for them, or it's not accessible to them, or they're not willing to seek it. And none of those is really the people that we were recruiting for this trial, because everyone in this trial some were referred by other providers, but many of them were reaching out to Strong Star, which is the research consortium this was part of. They were reaching out saying, I want to get help, I want to participate in a treatment study, and yes, I am willing to come in for multiple in-person baseline assessments, and I'm willing to be randomized to either web treatment or face-to-face therapy. So we just sort of realized that because the design we chose for this trial, we really weren't probably targeting the sample that you want to target for a web treatment. So fortunately, we did get approval to use the remaining money that we had for this project to do a small open trial of WebPE, and I'll tell you about that in just a minute. But first, I'll share with you the primary results of the RCT. Okay. So the demographics you can see here. There's nothing in particular I really want to highlight other than to say that these demographics look pretty similar to what we would expect from having done prior treatment trials, PTSD treatment trials at Fort Hood. So the sample looks kind of consistent with those prior studies. And then here is the primary, here's the change in PTSD symptoms over time in the two conditions. So you can see, I guess people can see my mouse here. So you can see that the WebPE participants started out higher than PCT, but this wasn't significant. This difference was not significant. Both groups showed significant reduction in PTSD symptoms over time. And in this small sample, so this was 19 people in WebPE and 21 in PCT. In this sample, the time by treatment effect was not significant. We did see significant differences in you can see in attrition. There's higher drop in the WebPE study than in PCT, and the PCT participants also had more therapy. So almost all of those participants did all 10 of the treatment sessions, whereas for WebPE, it was much more spread out. People did 4 or 6 or 8. It was just much more variability, and that did result overall in there being a difference in how the mean number of sessions that the participants received. The average reduction in PCL symptoms was modest in both groups, and you can see the effect sizes there. This this figure shows the change in PCL, and I chose that because for the open trial, we only had PCL, and I'm going to be presenting those data in a minute. We did collect the CAPS for this study, and the pattern was the same for the CAPS. So significant reduction in both groups and not a treatment effect. So I was a little disappointed in these results. I was hoping that the treatment would be more helpful for people. On the other hand, I recognize that centered therapy is a good treatment. It was found in the same population at Fort Hood. It was previously found to be non-inferior to face-to-face prolonged exposure. So it's a good treatment. It's not like a chump comparator by any means. But nonetheless, it was, you know, hoping to see better findings than this. Okay, so now I'm going to talk about what we were able to do next, which was a small open trial. And hold on. All right, now my mouse is not. I'll just do it like this. Okay, so we had a small open trial. We were trying to target 40 participants, recruited them nationwide. We used online ads, like Facebook ads primarily. And there was no randomization. So everyone in the study was signing up because they wanted to do WebPE. That's a big difference. We did assessments pre and post and 3 months, although at some point we actually stopped doing the 3 months so we could extend recruitment a little bit. The treatment itself was exactly the same. So the program was the same with a therapist. The therapist basically checks in sort of on the back end after the session is done. They can review the information, and they can reach out to the participant and say, you know, good job, or offer some corrective feedback as needed. So the program itself was the same. And yeah, I'll have to use it from here. Okay, so for the open trial, we had, in hindsight, pretty naive expectations about how quickly we could recruit people for the study. But nonetheless, we did manage to get 34 participants enrolled into the study. So, you know, almost twice as many as in the RCT, in the WebPE condition. And I will now share the results. So the sample here broke it out by gender, not really for any particular reason, but the main differences in the samples is kind of interesting. There was a much higher proportion of women in this open trial sample than in the RCT. And it was also more diverse in terms of, at Fort Hood, it's all active duty soldiers. So these are all people that are, you know, working full time and pretty busy with that, as opposed to, you can see the employment percentages in this sample. We had greater variability. There's also, I regret I don't have this on the table here, but I can tell you that there was a higher proportion of veterans in this sample than at Fort Hood. Again, that was all active duty. This was any active duty or veteran anywhere in the country that wanted to do WebPE. So more diverse sample, which is interesting. All right, okay, and then the PTSD change in this sample, you can see really nice reduction in PTSD symptoms over time. So pretty happy to see these findings. Attrition was similar in this sample, about 40% drop from the 1 month follow-up and more from the 3 month, though again, part of that is because we stopped collecting the 3 month. Treatment dose, this is interesting. So there were more people in the open trial that did not start treatment. So there were 4 people that they enrolled and then they just kind of disappeared. They never started the program at all. When you exclude those people, so among those that actually started the program, the dose that they received was higher than in the RCT. It was a little bit higher, but we just had more people that never started in this sample. The average PCL reduction was 27 points, so pretty nice reduction, and effect size you can see there. All right. In addition to the quantitative data that I've presented, we collected some qualitative information from participants in the WebPE condition of the RCT and participants in the open trial. And we did a brief phone interview at post-treatment. And I want to share with you some of the themes that came out in that qualitative data. So there's a couple themes that were, some of them came up in both the studies, some of them came up in only one or the other, there's some interesting patterns to this that I'll highlight as we go. But one of the really major themes was the value of the therapist. So an illustrative quote is having the therapist help with accountability, and I really need that. In the past, when I had therapy, I never had a therapist I actually respected. This time, I felt the therapist was really on point and knowledgeable and followed up, and I felt a connection. So this is great. The therapists were really well regarded. Their engagement with participants was really highly valued. I will say that we had pretty phenomenal therapists, so this is not surprising to me at all. They were very experienced, highly expert in treating military populations, and a lot of expertise in prolonged exposure. The other main theme that came out was the flexibility of doing therapy online or at home. So for example, the biggest help was being able to do it on my own because of the flexibility of doing the sessions when I could, instead of how it is at the VA when it's scheduled for certain times. And if you miss it, you wait a long time for the next appointment. So I think being able to do the sessions at a time and a place of participants choosing was really a big advantage of this program. This theme was prominent in both the study samples, but it came up a little bit more in the open trial than in the RCT. Okay, somewhat less prominent theme, but another thing that came up was technical problems. And we did specifically ask every person, did you have technical problems? So we were asking about this. For example, yes, sometimes my computer acted funny. I went on vacation. I couldn't do treatment. The technical problems were not that uncommon, but they varied a lot in the degree to which they disrupted engagement. So some participants said, oh, I think might have had a thing or two, a glitch or two, but it wasn't a big deal. Whereas some people said, yeah, there was this problem and it was annoying. The strange thing is that this seemed to come up more in the open trial, which was later, and we were trying to fix things kind of as we went. So I'm not sure really what to make of that. Challenges engaging. So about half of the participants said that they did have some difficulty, at least some difficulty, finding time to complete therapy activities. For example, I work full time. It was hard to find time to do the sessions sometimes. I usually did them in the evening, even though you're not supposed to do the imaginals before bed. It's the only time I had. Or sometimes I would do part before work and part after. So this seemed to be a challenge for, again, at least about half of the participants. This theme was more prominent in the RCT than in the open trial, and think this could be because the open trial participants were all active duty working full-time, whereas there was more variation in employment status in the open trial, but that's speculative. Okay, wanting more in-person therapy, for example, incorporating some group classes so you can get some support and discuss problems. This came up often when we asked people, like, what changes would you think we should make to this program? So people would suggest things like this. Wanting more support came up more in the RCT than in the open trial. So again, I think even in the pattern of these themes, you can see, to me, they kind of highlight this hypothesis I have about how the RCT sample was not, there was a mismatch in the fit of that sample with the WebPE program, and that the open trial participants were just, it's a better fit for them. All right, there's a few other themes, and these ones came up only in one study or the other. So the one that came up only in the RCT was about assessments. The assessment appointments were the worst, really long, difficult to fit into work hours. So many, not all, but many participants did seem to find the assessments to be kind of burdensome. This was only came up in the RCT because it was only in the RCT where we were doing in-person interviews, the structured interviews, and we had a larger assessment battery. In the open trial, we were just, PCL was our main outcome, so it was a really streamlined online assessment only. Okay, and then two themes, final two themes, these only came up in the open trial. The first is program usability and features. It's easy to navigate, the information's right there. Even a person who didn't know a lot about computers could navigate it. There's a lot of information, but not too much information. The videos were short but direct. So this is interesting to me that this only came up only in the open trial. Did participants really talk about, hey, I liked the program a lot, it was easy to use, or the videos were good and helpful? Again, I think this relates to that fit hypothesis that I have, that this only came up in the open trial. And then the last theme here, some of the participants, again, only in the open trial, talked about the advantages of the specifically in reference to traditional face-to-face therapy. So for example, I really liked being able to do the imaginal exposure by myself instead of in front of a therapist, because there was no pressure and I could just focus on the memory because I was comfortable, but wasn't distracted thinking about someone's reaction. So this is really interesting. A lot of the open trial participants did say they felt comfortable with how WebPE was delivered, and most of them felt that the anonymity of the online format actually promoted greater openness in their emotional expression. And this, again, didn't come up in the RCT at all. So those are the qualitative themes. In addition to looking at symptom changes and symptom scores, we also asked people if they thought the program was helpful for them. And so we asked them that in the qualitative interviews that we did. And then we also had a survey that asked a number of things, but had some questions that kind of mapped onto that as well. So I'll share a comparison of the two studies on helpfulness of the program. So at the top, we have the qualitative data. This is from the interviews that we did post-treatment. These were not the response options, but these represent the categorizations that I made based on participants' responses to the question of on the whole, was this program beneficial for you? Did it help? So you can see pretty consistent pattern across these different indices. The open trial participants, many more felt it really helped them a lot relative to the RCT. And then the survey data, so these are percentages of participants who said they agree or strongly agree with those statements. And then the PCL data we've seen before, but just to compare it there, and then you can also see there's much higher proportion of the sample that had a good chunk of reduction in symptoms. All right, lessons learned. Oh, I guess this is coming up one by one. I did not know that animation was there. Let me just bring it all out. Okay, lessons learned. Okay, I think I'll just start by saying it would be pretty hard to overstate how much I learned from doing these studies. This was actually really my first grant that I had as a PI of my own treatment grant. So I learned a tremendous amount, and I'm very grateful for my mentors and for the opportunity to do the open trial when the RCT wasn't recruiting, because I think that allowed us to get a much richer picture of the potential of this program and really test it in what I think is a sample that's a better fit. Okay, so lessons learned: WebPE is effective in significantly reducing symptoms of PTSD. This was more true in the open trial than in the RCT. And my hypothesis, again, is just about the fit and the comparator in the RCT altering the sample in a way that makes it harder to interpret that data. Both of the studies, full treatment engagement was a challenge. This is really a challenge for all internet delivered treatments. I don't think it's particular to this program. I know that at least some participants did benefit in terms of their symptom reduction, and they only completed like 6 sessions or 8 sessions, and they just didn't get around to doing the last of the end of the program. So I think potentially, using like a variable length design where you're providing treatment until the participant achieves a particular amount of symptom reduction, using that to determine termination rather than having a fixed number. I think that might mitigate this a little bit. The other idea I had was maybe finding a way to be more responsive about the amount of human support that participants want. That could potentially help as well. One of the really big lessons learned for me in doing this is the importance of considering the target population when selecting a comparator. I think particular when the format of treatment delivery is different, it makes it really hard to interpret the findings. I think people do have preferences about, I want face-to-face therapy, I want online therapy, I want group therapy, or I want to be, with my partner in therapy. So I think when those are not, the format of delivery is different, I think it's harder to interpret the data, and you're maybe not testing your treatment on the target population. Another big take home is that the convenience of the WebPE program, being able to do it at home when they had time, was a really big advantage. And another important point is that the therapist support, human support, is really, really crucial. This was already pretty established from the broader literature, but was quite salient in our findings as well. I think what's less clear is how much is needed. Most of the participants in my studies said they were happy with the amount that we provided, but then a significant minority were left wanting, and wanting more support, more therapist interaction. So one of the directions I'm moving with some of my current work is actually related to understanding that role of human support in internet or mobile health, internet treatments or mobile health. So, So this question of who can provide support. I have one study that is, I'll tell you a little bit about, and it's delivering the written exposure therapy protocol. It's delivering that online and actually using, instead of therapists, using trained peer support specialists in that role. So that's one study that I'm doing. And then another is developed a mobile app for PTSD symptoms. And in this program, the user is asked to select their own support team or support person who then reinforces their engagement with the program and checks in on them. So, who that support person can be and kind of what we can get away with. And that is an area that I'm really interested in, because these approaches are, they have a high cost effectiveness and they're much really high scalability. So that's an area I'm working on now. And I'll tell you a little bit more about those two studies. The written exposure therapy treatment is developed by Denise Sloan and Brian Marks. Some people might be familiar with this existing evidence-based treatment for PTSD. It's a brief, typically 5-session in-person treatment where the participant just writes about the trauma and then the therapist sort of checks in before and after. So I thought it's pretty good for translation for online delivery. And we're going to be recruiting 300 veterans from among users of a Vets Prevail website, and using a variable length design where they will receive between 4 and 8 sessions, depending on their rate of symptom reduction. And then we have trained peer support specialists. Vets Prevail actually has contracted with peer support specialists, so they're almost available 24/7 on the platform. So they will be with the participant and providing synchronous feedback, like immediately after the writing, doing the check-in. So it is really mirroring what happens in a face-to-face session. The mobile app study, the app is called Renew. There's a number of different features and components to it. The main ones are Approach, which is in vivo exposure, Process, which is written or narrated exposure, and then Self-Care, which is like relaxation and kind of behavioral activation type things with a focus on social connection and physical activity. We tried to make the app fun to use, so you can earn points by doing different activities. You can achieve different levels. When you do, we have this sort of recurring image of this seedling, and it grows and it can become a tree and you get higher levels. And a really cool feature, I think, is the support team. So the user can select their own support team or person, and that person gets their own version of the app. It has information about PTSD, about avoidance, about the Renew program, and it gives them instructions in how to provide reinforcement. They get notified when the user engages with the app, when they earn points and so on, and they're instructed to provide reinforcement. They're also instructed to check in on them if they haven't used the app in a certain period of time. So that's some work that I'm involved in currently. All right, in conclusion, again with the, okay, that's it. So In conclusion, I think there's so many known barriers to accessing mental health treatment for PTSD that is as it's traditionally provided in face-to-face sessions. And increasingly, consumers want access to healthcare independently. They want to interact with providers, you know, at the time and place of their choosing. And there's just this shift to kind of expecting to be able to get things on demand. And I think this is true for a lot of services, including behavioral health care. In addition, the adoption of technology is increasing so rapidly. I was thinking about telehealth, like video conferencing, and how that seemed like really pretty novel quite recently, and it's now part of standard care. The evidence base for internet delivered treatments is increasing quite quickly. Again, I think it's much more established for other disorders than PTSD, but we're getting there. The use of self-management tools, I think, is really quite widespread at this point. And given the rate of the anticipated you know, continued spread of these technologies really all around the world, I think there's a lot of potential for them to make an impact in the burden of PTSD. So again, to accommodate, to address the known barriers to accessing traditional care and to accommodate these shifts in expectation and trends in technology adoption, we really need to continue to develop models of care that are flexible and that use technology to increase the reach of effective treatments to people that may benefit from them. So I'm going to end with that. I have a slide of references here, but I'm thinking I'll just ask if anyone needs anything or has any questions about that to let me know. And I do want to have a moment just to thank my mentor on the grant, Dr. Foa. Dr. Peterson is the director of the Strong Star Research Consortium that supported the WebPE study. So thank you to Dr. Peterson for his mentorship. Thank you to the entire Strong Star Consortium, the people that did the assessments, the therapists, so many people working behind the scenes to support this work, and the National Center for PTSD for supporting me and my work as well. Thank you.
All right, thank you so much, Dr. McLean. All presenters, you may now have the opportunity to ask any questions. As a reminder, you can submit all questions into the chat box on your attendee control panel. So we'll give participants a few minutes to think of any questions and type them up. Okay, we have one question. When the therapist checked in and supported clients during treatment, how did they communicate? Through text, email, or video?
Yeah, that's a great question, and I'm remiss for not having explained that, but all of those things. So they would review the session. So the participant was supposed to complete each session kind of within a window of time, because we did want to keep them on like a schedule of some kind. So the therapist would kind of be checking in to see if they had done their session, and then when they did, they would review the information the participant had inputted, and then they would reach out to the participant either by email, by phone, or by text message, and that would really depend on what sometimes I think they asked the participant at the beginning of the program, they asked them about preferences and how they wanted to be contacted, so that would determine, that would influence that decision. And then also the nature of the feedback. So if everything looked good and the therapist just wanted to say, thanks so much for doing your session, like fantastic job, and provide some reinforcement, they might choose a different, you know, modality than if they had a concern that they felt they needed to kind of discuss with the participant.
All right, thank you. We'll give it a few more moments for people to ask any more questions. All right, I don't think there are any other questions. I just want to say thank you to today's presenter and thank you so much, Dr. McLean, for doing this webinar presentation for us.
You're welcome, and thanks again for those who join and for the invitation.
All right, thank you. Have a great day.
Okay. Thank you. Bye.
Thank you everyone for attending today's training. You will receive an email shortly that includes the link to the webinar evaluation as well as a link to the recording of this webinar. For those seeking CE credits, the post-test assessment will be distributed after these few announcements. The post-test assessment will also be included in the follow-up email for anyone interested in completing it at a later date. Our next ADA Live webinar will be held on June 13th at 12 p.m. titled Spirituality and Mental Health, What Clinicians Need to Know, featuring David Rosmarin. If you are not yet an ADA member, we invite you to view the many membership benefits that ADA has to offer. Please visit ada.org to learn more. On behalf of ADA and our presenter, we thank you so much for joining us today. You will now have the opportunity to complete the post-test assessment. You must have registered for this webinar with CE credit, obtain a minimum 80% or higher on the post-test assessment, and complete the webinar evaluation with the provided 4-letter code in order to be eligible for CE. If you did not receive a score of 80% or higher, please email webinars@ada.org. I will now launch the post-test assessment. You may exit the training once complete.